Hi everyone, and welcome to our second webinar in our series of Noon Hour Lunch and Learns. Throughout April, Parkinson Association of Alberta is joining other like-minded organizations across the globe to bring people together in support of Parkinson Awareness Month. This April, we are raising awareness of the impact Parkinson's has on those who have received a diagnosis, the people who love and care for them, and our community as a whole. We are also focusing on hope through research, as many of our presentations will be dedicated to the incredible Alberta-based research that is so vital to our community. Did you know that over the past 15 years, this community, through Parkinson Association of Alberta, has invested more than $1.5 million in support of Parkinson's research in Alberta? We hope you join us in as many of these free virtual Lunch and Learn events as you can by registering online through our website. Today's webinar is kindly sponsored by Hine Financial Group. Our presenter today is Dr. Vikram Karnik. Dr. Karnik joined the faculty of the University of Calgary in 2021, works in the movement disorders, urgent neurology, and general neurology clinic, and splits his time between the South Health Campus, Foothills Medical Center, and Rocky View General Hospital. Dr. Karnik's presentation will be on clinical research into Parkinsonian syndromes and why patient engagement matters. As a disclaimer, this webinar will be recorded. All of the information provided in the videos by Parkinson Association of Alberta and its featured speaker will be furnished strictly for educational and entertainment purposes only. This service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, and/or care of your physician. General questions about symptoms, treatment, available medication, complementary and alternative healthcare therapies, and current research will be fielded. If you have any questions during the webinar, please feel free to enter them into the chat, and we will get to them at the end. So thank you, and welcome, Dr. Karnik.
Thank you so much. Let me just share my slides here. Can everyone see those okay? Amazing. Thanks everyone for joining us over the lunch hour today. And thank you to the Parkinson Association of Alberta for having me. As was mentioned, the theme of some of the webinars this month is hope through research. And so today, I hope to talk about Parkinson's disease and Parkinson's plus syndromes and clinical research into these conditions and why patient engagement in research matters. To start off with, I just want to acknowledge that our work is being performed on the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary, where I am, is also home to the Métis region of Alberta, Region 3. Métis Nation of Alberta, Region 3, sorry. And so a brief outline for our talk today. I think where we should start is just kind of distinguishing Parkinson's disease from some of its cousins. I think, that'll kind of provide us with a good foundation where we can lead into some of the clinical research that's been done. Beyond that, we'll talk about some of the advances that we've made in the last 20, 25 years and why patient engagement in that research was so important. And then we'll talk about ongoing clinical trials in Parkinson's disease and Parkinson's plus syndromes and future directions and where we may go in the next 5, 10, 15 years. So to start off with, let's just talk about Parkinson's disease in general. I know we're all, or most of us are fairly familiar with the condition, but the more obvious symptoms that we do talk about are the motor symptoms. And so the most common motor symptom that we see in Parkinson's disease is slowness of movement or bradykinesia. And that involves difficulty with fine motor movements, sometimes difficulty with larger amplitude movements. But on top of that, on top of the slowness, sometimes people experience some stiffness, sometimes people experience tremor, and sometimes there can be changes in walking as well. But one of my colleagues, Dr. Bruno, often describes the hidden symptoms. And so these are symptoms that are not commonly talked about, but are often associated with Parkinson's disease. And those can be things like pain, changes in sleep pattern or very vivid and active dreams, dizziness or lightheadedness when people stand up, changes in urinary habits, so urgency of urination, frequency of urination, changes in bowel habits like constipation, which can often precede Parkinson's disease by many, many years, mood symptoms like severe depression or anxiety, and then some cognitive changes can sometimes come on. And so those include memory changes or visual hallucinations. And these symptoms are not publicized or not talked about more commonly because they're not overt. They're not something that can be seen, but often are quite disturbing in terms of quality of life. And so those are just, obviously a brief overview of some of the symptoms that people with Parkinson's disease can experience, but the cousins of Parkinson's disease can also look similar, especially early on. And so while these conditions can have stiffness and slowness and some of the other things that we talked about, they are a little bit different in other ways. And I'd like to talk about each of these conditions now. So progressive supranuclear palsy is one, or PSP. Multiple system atrophy is another, MSA. Cortical basal syndrome, or cortical basal ganglionic degeneration, CBS or CBGD. And then dementia with Lewy bodies, or DLB. And each of these conditions, like I said, can look like Parkinson's disease early on, but there are some key distinguishing factors which develop over time that help us delineate between the two. The other important thing to keep in mind is they're far rarer than Parkinson's disease. And so while Parkinson's disease can affect 1 in 100 people, up to 1 in 100 people, PSP, MSA, and CBS are far more rare, affecting between 5 and 10 in 100,000 people. The dementia with Lewy bodies is slightly more common, but again, far more rare than Parkinson's disease itself. So looking at PSP, or progressive supranuclear palsy, how is it different from Parkinson's disease? Well, unfortunately, it usually does progress more quickly, and gait difficulties can lead to earlier falls. It's also usually more symmetric, where we usually see a more asymmetric presentation in Parkinson's disease. Speech and swallowing changes can occur far more early in the course of progressive supranuclear palsy as well. And then the hallmark feature is eye movement abnormalities. And so that's where the progressive supranuclear palsy got its name. The supranuclear palsy refers to difficulty with eye movements. There can also be earlier cognitive changes in PSP as compared to Parkinson's disease. Multiple system atrophy, or MSA, is also different in that the autonomic symptoms, so the autonomic nervous system, tends to be affected earlier on than in Parkinson's disease. And the two symptoms that we classify are the lightheadedness, so getting dizzy or lightheaded when one stands up, and that's caused by a drop in blood pressure, or urgency, frequency of urination, or sometimes urinary incontinence. And these symptoms are the core symptoms of MSA, which are present far more early in MSA than they are in Parkinson's disease. A key thing to note is that people with MSA may actually not have Parkinsonism. So that means they may actually not have stiffness, slowness of movement, or tremor. That's because there's a cerebellar subtype of MSA, which means that the difficulties are more common with gait, or walking, or in coordination of the limbs. And so I think that's an important thing to clarify, is that you may be diagnosed with MSA, but you may not actually have symptoms of Parkinson's disease itself. Cortical basal syndrome, again, is slightly different from Parkinson's disease. It is asymmetric, like Parkinson's disease is, but we do see more prominent cognitive changes early on. And these are not the usual cognitive changes like short-term memory impairment, but they involve other things like difficulty discerning what object you're holding in your hand. Like, if we hold a pencil or a set of keys in our hand, we can kind of tell what that is. But sometimes people with cortical basal syndrome have difficulty doing that. There are other cognitive changes that can sometimes occur that are a little bit different as well, such as planning motor movements in a different way than we see in Parkinson's disease. And so, for example, doing some hand gestures like a peace sign or a Spock sign can sometimes be difficult. Other atypical movements can come on, and so things like dystonia, so cramping of the limbs, which we can see in Parkinson's disease, can happen. But sometimes jerking movements of the limbs or the trunk, which we call myoclonus, can occur. And sometimes there can be difficulty controlling the limb altogether, and the arm can kind of move, or the leg can kind of move on its own, and we call that an alien limb. These are rare features that sometimes can be seen in cortical basal syndrome, but aren't seen in Parkinson's disease. And again, people with cortical basal syndrome may not have those same features of stiffness and slowness that we see in Parkinson's disease. And so you could be diagnosed with this condition without having symptoms that typically would be seen in Parkinson's. And lastly, dementia with Lewy bodies. So DLB, again, we can see more early cognitive changes, and that's the hallmark feature of distinguishing dementia with Lewy bodies from Parkinson's disease. Hallucinations can be present very early on as well. And again, as was with MSA and dementia with Lewy, and cortical basal syndrome, you don't necessarily need to have the stiffness and slowness to be diagnosed with dementia with Lewy bodies. And so early on, there can be a lot of overlap between Parkinson's disease and the cousins, but over time, often we allow the diseases to kind of declare themselves, and these symptoms can be quite different and debilitating in different ways. I think, beyond symptoms, it's also important to understand what happens in the brain, because this will kind of circle back to some of the discussions that we have later on in terms of how do we slow down or alter the course of the disease. And so when we do autopsy studies, in PSP and CBS, we find a protein called tau in the brain. And in Parkinson's disease, MSA, and dementia with Lewy bodies, we find a protein called alpha-synuclein. And so why two different proteins can sometimes cause similar symptoms, and why the same protein can cause a variety of symptoms presenting as different diseases is still a matter of research. And we still don't know why, for example, alpha-synuclein in some people causes Parkinson's, while it attacks other parts of the brain and causes multiple system atrophy in other individuals. And so, using that basis of the knowledge that we've gained now with the symptoms that we see in Parkinson's disease and its cousins, and knowing that two different proteins can cause similar symptoms and can attack different parts of the brain, causing different diseases, we have the foundation upon which we build clinical research. And so our research pathways can kind of branch off in two ways. One is we can try and target those symptoms that we talked about. So that whole host of symptoms that we see in Parkinson's disease and some of the different symptoms that we see in some of the other conditions that I talked about. Or do we go down the path of trying to slow down and stop the disease process at its source? So do we try and target some of those proteins, or do we try and find different mechanisms by which we can alter the disease course? And so I'd like to kind of explore some of these pathways now and why patient engagement in research matters. So let's talk about symptom management first. And I'd like to picture a 65-year-old gentleman who's diagnosed with Parkinson's disease all the way back in 1995. And so that's 27 years ago now. So in terms of treating Parkinson's in 1995, we were kind of limited in our options. We had some oral medications. So that's levodopa, so the dopamine precursor, which our body makes naturally. We had synthetic dopamine mimickers. And so those are agonists, which means they bind the dopamine receptors, but look a little bit different than dopamine, and stimulate the receptor to have the same effect or a similar effect that dopamine would. And then we had trihexyphenidyl, or Artane. And that's a medication that's quite helpful for tremor in Parkinson's disease, but sometimes comes with other side effects like cognitive changes or dry mouth. We also had some advanced therapies beyond just our normal oral medications, and that included things like thalamotomy, where a hole was made in the thalamus to disrupt the circuit that caused tremor. We also had deep brain stimulation, believe it or not, back in 1995. But again, that was in the thalamus only. So it was only approved for tremor back then. And then we had subcutaneous apomorphine injections. And so apomorphine is one of those dopamine mimickers, which we didn't give by mouth, but we actually gave under the skin in injection form to try and treat people who weren't feeling the full effects of their oral medication. So in the off time where the medication wasn't fully kicked in. And so while we had a variety of options, the prevailing thought back then was obviously we need more. And that's because the symptoms were up and down and highly debilitating. We still didn't have disease modifying therapy. And so levodopa had been around for almost 30 years by then, and we still didn't have anything that slowed down the disease course or disease process. And, there was a very wide spectrum of disease in Parkinson's. And so some people had tremor as a predominant symptom. Other people, the stiffness and slowness was a predominant symptom. And for other people, it was walking impairment or gait impairment. And so could we kind of narrow down our focus and help just the tremor or just the stiffness and slowness or just the walking, and create more individualized treatment from that standpoint? And so where have we come in the last 25 years? And so even from an oral medication or medication standpoint, we've made significant progress. So now we have different formulations of levodopa. Rather than the immediate release formulation, we've also got a controlled release formulation, which is a more slow delivery over time. We've also developed a medication called Rytary, which is now only available in the US, but should be coming to Canada. where you get an immediate release capsule, a medium release capsule, and a delayed release capsule all in one to try and smooth out the delivery of medication. There's also inhaled forms of levodopa which are available. We've developed more dopamine mimickers or agonists, so things like pramipexole and ropinirole, where they bind the dopamine receptor to try and give people benefit in that way. We've also developed monoamine oxidase inhibitors. So those are things like rasagiline, selegiline, or sulfonamide, where it prevents the breakdown of dopamine in the brain to try and prolong its effect. COMT inhibitors, so things like entacapone, again, to try and prevent the breakdown of dopamine and prolong the life of levodopa. We've also developed patches, and so these are little patches that you can put on your skin where medications are delivered through the skin, and this is for a dopamine mimicker or agonist called rotigotine, and so that's a continuous delivery of the medication through the day under the skin. We've also got sublingual dissolving tablets now, so kind of things like Listerine pocket packs where you can kind of pop them under the tongue if you're feeling like the medication hasn't really kicked in, and it gives you a bit of a boost to get through the rest of that off period. We've also developed new mechanisms of medications that use new mechanisms of action. And so all the medications that I talked about act on the dopamine receptor. There's a new medication that's out there that actually acts on a different receptor called adenosine. And so adenosine is thought to modulate dopaminergic activity in the brain. And by blocking the adenosine receptor, it's thought that dopamine can be more free flowing in the brain. And so this medication should be available in Canada very, very shortly, and is just been available in the US for the last year or so. And so you don't get those same dopaminergic side effects that you would from all the other medications. Typically, the side effect profile is quite a bit better because you're acting on a different receptor. And so on top of the oral medications or patches or sublingual tablets, we've also developed some significant advances in our advanced therapy, so beyond just medication. And so starting with surgical options, we've developed advances in deep brain stimulation and focused ultrasound. And so I'd like to talk a little bit about those now. For those of you that don't know anything about deep brain stimulation or DBS, I'd like to kind of walk you through what that process looks like. And so this is on the right here, you can see a schematic of the electrodes that actually get inserted into the brain. And so what these look like are basically you've got 4 contact points, 1, 2, 3, 4. And these 4 contact points are where we can deliver electrical stimulation to circuits in the brain that can cause symptoms in Parkinson's disease. And so what happens is these electrodes are put one on each side of the brain, or sometimes just on one side of the brain if the other side of the body is problematic. And they're connected to a battery pack that sits in the chest wall. After the surgery is complete, the neurologist then connects to that battery pack in the chest wall using a tablet. And then electrical stimulation is delivered to, let's say, this first contact point here. And we slowly increase the stimulation delivered to that contact point until we see benefit or side effects. And so then we go back down and then try contact point 2, then number 3, then number 4, and then we go to the other side of the brain and do 1, 2, 3, 4 again. And so our goal here is to try and find the optimal contact point on either side of the brain to try and disrupt the circuit that then improves symptoms of Parkinson's disease. And the goal here is to provide continuous improvement, because with oral medications, understandably, there's a peak and then a valley as the medication starts to wear off, and then you need to take your next dose. But with deep brain stimulation, it's thought to be a continuous electrical delivery of electric medication or stimulation to try and prevent those ups and downs. And so understandably, with deep brain stimulation, there's a lot of hope, but there's some problems that come with it as well. And so better technology is needed because motor benefit is heavily dependent on the accuracy of insertion. So we've got fantastic neurosurgeons that are really adept at putting these leads exactly where they need to be, but even a ½ millimeter here or there can sometimes be problematic in a very deep, sensitive part of the brain. Understandably, as we build up the stimulation, sometimes we can get side effects because we're affecting other parts of the brain that are functioning normally. And so stimulation-induced side effects can be quite common. As Parkinson's disease progresses over time, sometimes the DBS does need to be adjusted. And so those adjustments over time can take up a lot of resources. And lastly, the battery pack in the chest wall needs to be either charged repeatedly or replaced over time. And that can be problematic because it requires further surgeries or other things to be done by people at home. And so all of these reasons are why we kind of push for better technology in DBS. And I'd like to share some of the progress that we've made in that regard. Step one was what we call directional stimulation. And so if you look at the schematic at the top, we're now looking at a horizontal cut of that same electrode that I showed you earlier. And so if we go back a couple slides, we're now looking at a cross-sectional cut right through one of these contact points. And so the green spot here is what we call the sweet spot. That's where we want to deliver our electrical stimulation to try and prevent some of the symptoms of Parkinson's disease. The red spot is the sour spot, where if we stimulate, we'll get side effects. And so understandably, if we just stimulated a big sphere around that contact point, we're going to hit both the sweet spot, but we're also going to get some side effects. And so now with directional stimulation, we're actually able to turn and point our stimulation and shape it in a way where we can push it directly towards the sweet spot and then avoid the sour spot. So we can get only benefit and avoid the side effects. And this is something that we've only seen in the last 3-4 years, where we're seeing far better outcomes in terms of reduced side effects and better symptom control. And so although the surgeons are incredible at what they do, sometimes a 0.5 millimeter difference here or there can be compensated for based on our ability to turn and shape the stimulation in a certain direction, to point it away from a part of the brain where we could get side effects. Beyond directing where we can send our stimulation, there's also this concept of adaptive DBS, or adaptive deep brain stimulation. And so this is a lead that can then adapt to fluctuating symptoms over time. And so, for example, if someone has tremor and it's really bad at 6 o'clock, what this lead is able to do is sense the brainwave activity around it, which portends that someone's going to have worse tremor. And so if there's more brainwave activity going on, that would then imply that the tremor's bad, and then the lead would turn on and produce more stimulation. But when the tremor's gone, let's say at 7 the next morning, the brainwave activity is reduced, and then the lead would kind of back off, and you would have less electrical stimulation. And so this is thought to generate fewer side effects because it's only active or produces more stimulation when it needs to, and therefore it improves battery life as well, right? So you're not giving that constant big stream of electrical stimulation all at once or all the time, only when the symptoms are actually there. And so as of 2021, last year, the sensing technology, so the ability to look at those brain waves and for the contact to actually sense those brain waves, that technology has been approved. And so we can actually use that technology to do the programming sessions when people come in after deep brain stimulation. The adaptive piece, where the electrode responds itself to the level of brainwave activity that it gets, is not quite there yet. It hasn't been approved. The trials are ongoing right now, but it's coming very, very soon. And so it's quite an exciting time for deep brain stimulation. So those are some of the changes that we've made over the last even 5 years with deep brain stimulation that have really, really improved the way we can manage symptoms. High intensity focused ultrasound is another way that we've adapted our surgical techniques to improve patient outcomes. And so making lesions in parts of the brain to try and improve patient symptoms is not a new concept. It was first used way back in the 1950s, but naturally, as deep parts of the brain were being targeted, there were a lot of side effects with those surgeries. But modern advances now, have allowed for far less invasive lesioning. So you're still making a small hole in a circuit in the brain that causes tremor or slowness or stiffness of movement, but you no longer need to open up the skull. And so with high intensity focused ultrasound, we can kind of target a part of the brain that we want to create a small lesion in with only a head shave. It doesn't require opening of the scalp or the skull, which obviously reduces the risk of bleeding and infection and things like that quite a bit. And so sometimes deep brain stimulation can be quite an intimidating option because things are being inserted into the brain, and this can portend a risk of infection and things like that. High intensity focused ultrasound is a far less invasive procedure, although still creating a lesion in the brain that sometimes is tolerated a bit better. Of course, the difference between the two is deep brain stimulation, you can kind of adapt and adjust over time. The focused ultrasound is burning a small hole, and so it's a permanent thing that can't really be adjusted, right? But of course, the safety that comes with it is the significantly reduced infectious risk and the tolerance during the surgery itself. So beyond surgery, we've also developed some new infusion therapies which have greatly improved symptomatic control of Parkinson's disease. The first of which is something that I think people will be familiar with, and that's levodopa carbidopa intestinal gel. So this requires a G tube or insertion of a tube into the stomach, and then continuous delivery of a gel formulation of levodopa. And so again, this is thought to reduce the ups and downs that come with taking a medication by mouth, and rather give a continuous steady stream of medication into the gut. A newer option that's coming soon and is currently completing clinical trials is subcutaneous levodopa. So this concept was borrowed from type 1 diabetes, where people have insulin pumps. And so this is now an option where people can have levodopa pumps just attached to the arm or to the abdomen. And it's a continuous delivery of levodopa under the skin. And the reason it took so long to develop is actually stabilizing the levodopa molecule to deliver under the skin was actually really, really hard. But we've now developed multiple formulations where that's possible. And where it's different from the intestinal gel is it doesn't require a G-tube insertion. And sometimes we don't deliver the intestinal gel overnight. The levodopa subcutaneously can actually be delivered 24 hours through the night as well in some formulations. And so I'm hopeful that that'll come to the market very soon because the trials are just finishing. So the medications that I've talked about so far and the surgical options all relate to the motor symptoms of Parkinson's disease. But as mentioned, the non-motor symptoms can be quite debilitating as well. And I'd like to highlight two neurologists that work here in Alberta, just because they've dedicated the bulk of their research work to non-motor symptoms in Parkinson's disease. So things like pain, sleep, mood symptoms. And so those are Dr. Janice Miyazaki on the left, who works up in Edmonton, and Dr. Veronica Bruno here in Calgary, who have dedicated the bulk of their research to these non-motor symptoms. So lots of new options coming out in terms of non-motor symptoms as well, and too many to talk about. But if you'd like to look at what Dr. Bruno and Dr. Miyazaki are up to, I encourage you to look them up on the university websites, because they're doing a lot of really great work for the less obvious symptoms in Parkinson's disease. But the key to all of this, of course, is our patients. And so when you think about all those different medications that we've developed since 1995, the advancements in deep brain stimulation and focused ultrasound therapy, the therapies that we're developing for non-motor symptoms, that requires thousands and thousands and thousands of patients to give up time and effort to come in to participate in trials, which is not an easy thing to do because of a variety of factors, right? Sometimes people don't live in the city and it requires a lot of travel. Sometimes ambulating and getting into clinic can be really tough. Sometimes it's hard to even find a ride to come to frequent visits. And so really the key to progressing through research is working as a team with stakeholders in the community, with physicians. But the most important piece is people that are willing to give up time and energy to come in and help participate in trials like this, like the ones that I've discussed, sorry. But as you can see, what I've talked about so far are symptomatic therapies in Parkinson's disease. And so I haven't talked about any disease-modifying therapies yet. And so this remains the search for the Holy Grail, because while we can control symptoms a lot better than we did in 1995, we still don't have any therapies that we can give to slow down progression of the disease itself. And so how do we develop that path forward? What do we do? And so going back to one of our first slides that we talked about, remember those two proteins that we discussed, tau protein for PSP and CBS, and alpha-synuclein for Parkinson's disease, MSA, and dementia with Lewy bodies? Do we try and target those proteins to try and remove them from the body and see if that slows down the disease course? Or do we go for more of a precision option, meaning do we look to try and treat people with only specific genetic mutations? Like, for example, a LRRK2 mutation, LRRK2, which is a very, very common or I shouldn't say very common, but one of the more common genetic forms of Parkinson's disease? Do we try and target that mutation specifically and then build up to the population as a whole? Or do we look at something like stem cells or and try and develop individualized treatments rather than one drug that's given to everybody? And so let's talk about the protein targeting option first. And so this is from 2019, and these are all the different studies, that the clinical trials that looked at targeting alpha-synuclein and removing it from the body in one way or another, either preventing its buildup in the brain or getting the immune system to attack it. But there are several studies that were either just starting or planned to start or were actively recruiting at the time. And so the one that was published first was this Pasadena study. And so these are a bit complex in terms of the graphs, but I'll walk you through them here. So the blue line here is the placebo medication. The red line here is a low dose form of the medication. And the black line here is a high dose form of the medication. And basically what this medication was it was given in the spinal fluid through a lumbar puncture to try and then bind the alpha-synuclein protein. And then the immune system would then think that this was something it needed to attack and get rid of it from the brain. And so we showed that giving this medication in the spinal fluid actually removed the protein. But now these graphs, what they look at is whether people actually got better. And so when we compared baseline motor symptoms to symptoms at 52 weeks, there was no significant difference. So people actually got worse at the same rate with placebo, low dose, and high dose medication. But when we looked at data in a different way, so the UPDRS part 3 is kind of one of the scales we use to measure how people are doing from a motor symptom standpoint. When we look at how long it took for people to get 5 points worse, there was perhaps a signal that showed that the drug was a bit slower than people that got placebo. So maybe there was some benefit there. And so the trial is being kind of rejigged to look at this in a bit of a different way, to say maybe we are slowing down disease progression. But the results were a bit disappointing in that when we looked at people a year later, symptoms looked about the same as those that received placebo. And so this caused us to kind of take a step back and say, hey, look, what's going on here? Why are we not seeing the results that we had hoped for? And so the question is, are we delivering the medication too late? And so once people have developed Parkinson's disease or are, 2, 3, 4 years into the course of Parkinson's disease, is it too late? Is this kind of a self-fulfilling prophecy? Do we need to give the medication like at diagnosis or even before people develop motor symptoms? Is there a way we can tell that people are going to develop Parkinson's disease 4, 5, 6, 10, 15 years down the line? And is that the time to give people this medication to clear that protein? Question 2 is, are we delivering it in the right way? Is it the right thing to do to give it into the spinal fluid, or should we give a medication by mouth instead? And is that going to change things? Is that going to change how we see, if we see a difference at a year or 2 years out? Question 3 we asked is, are we actually treating the same disease? And so remember that spectrum of disease I talked about where people have tremor, predominant symptoms, stiffness or slowness, or walking difficulty. Are we treating the same disease here where we're calling all of these Parkinson's disease? Or maybe we're actually dealing with different subcategories of Parkinson's disease or different diseases altogether. And so should we only recruit people with tremor predominant disease? Should we only recruit people with stiffness and slowness and see if this medication works in that group of people first before expanding it out to everyone who falls under the Parkinson's disease umbrella? And then the last and probably most obvious question is targeting the protein the right strategy. So we find these proteins on autopsy studies, but then the question is it actually disease causing? And we have genetic studies, we have animal model studies that suggest that perhaps this is the case, but maybe we need to think about things differently and think about the fact that maybe the protein targeting strategy isn't the right one. And so a lot of the studies that have been ongoing and recruiting are still in progress, but some of the earlier ones that have finished are now trying to alter either the timing of delivery, the method of delivery, who are being recruited into the studies. And so we're hopeful that in the next few years, we'll see some of the results turn out more positive than that initial Pasadena study because of how these studies are being kind of reworked. So moving on a bit from that protein targeting process, what about precision therapy? And so again, that kind of looks at genetic specific treatments. So there are ongoing clinical trials right now for people with LRRK or LRRK2 mutations. In Toronto, there are studies that are looking at people with specifically GBA mutations, with GBA is another form of genetic Parkinson's disease. But it's important to keep in mind that genetic Parkinson's disease makes up a significantly smaller proportion of Parkinson's disease as a whole, right? So when we look at genetic specific treatments, we're looking at less than 10% of people that have Parkinson's disease, right? So that's over 90% of people that these therapies wouldn't really work for. But if we do find treatments that can slow down progression of disease, then perhaps we can apply those concepts to the Parkinson's population as a whole. Something that comes up quite often is stem cells. And so I think it's an important thing to address. There was a paper that got a lot of fanfare and media attention back in, I think it was late 2020 or early 2020. It was published in a big journal, the New England Journal of Medicine, where an individual had his skin cells taken, and then they were in the lab, reverted back into stem cells. And then those stem cells were converted into dopamine producing cells. What happened then is this donor, the individual whose skin was taken to turn back into stem cells, he himself had Parkinson's disease. And he was actually a donor that funded all this research. So he donated something like $10 million to this research. And so they took the stem cells and put them back in this individual who was actually the donor for this study. And then subjectively, they showed that he felt a lot better at 6 months or 12 months out. The more objective methods of looking at whether he actually got better were kind of murky. And so understandably, if someone's donating $10 million to a study, they're going to feel better when they receive those stem cells back into their brain. And so I think there was a strong placebo response there. But there is hope that potentially something like this could be used down the line. Stem cell therapy and treatments were kind of all the rage in the late 90s, early 2000s. But I think, we've been kind of disappointed in some of the results that we've been seeing. And we take the results from this paper with a grain of salt, just because the donor himself was the one who received the stem cell transplant. There are a lot of anecdotal stories that we hear about people traveling overseas to get stem cell treatments which have either slowed down or stopped tremor or other symptoms of Parkinson's disease. But we don't have any data that suggests that this is what we call evidence-based. There's not big studies that show that this would actually work. And more importantly, we don't actually have studies that show that this is safe, right? And so we often hear that people go and do well, but we don't hear the stories of people that develop significant infection or significant other harms from surgeries or treatments that are not trialed in terms of their safety. And so there is work being done in terms of stem cells. And so in Boston, where I trained and where this study was done, they're recruiting now patients just in Boston for trying to develop those skin cells back into stem cells and then dopamine producing cells to try and scale up from that one patient that they published the paper on. So that research is being done, but I'd be wary of people or stories that you hear that this is a proven treatment, because it's not yet. So there are a lot of other treatments that I haven't talked about yet that we just don't have time for, but I do want to mention them. So other surgical options include radiofrequency or ablations or radiosurgery. And so this is another method of disrupting the circuits in the brain that can cause symptoms of Parkinson's disease. Gene therapy, so not genetic specific therapy, but gene therapies, where actually we take like a virus and put a little a gene in the viral genome that allows the virus to then produce dopamine. We take that viral vector and put it in the brain. It then goes into some of the cells in the brain, causing them to produce more dopamine or produce enzymes that prevent the breakdown of therapy. So there are surgical trials for gene therapy that are ongoing in certain centers in North America as well. There's some thought that perhaps Parkinson's disease is an immune-mediated process, so the immune system may cause symptoms, and so there's some work being done into immunotherapy. And then disease modification using known agents. So there's a lot of medications that have been produced for a lot of different reasons out there. Exenatide is actually a diabetic medication, but there's some thought that through a different mechanism of action, it could actually help slow down the progression of Parkinson's disease. So some work is being done into starting clinical trials looking at older, cheaper medications that may actually work in a different way. And then lastly, there's a lot of work being done into the gut microbiome and how our gut-brain axis plays a role in the development of symptoms and progression of Parkinson's disease. And so at the University of Calgary, there's a huge microbiome center kind of looking at how we can modulate individual microbiome to try and potentially alter the symptoms or slow down the progression of Parkinson's disease itself. And so I've talked a lot about Parkinson's, but what about the PD plus syndromes, right? Because that's part of the talk here too. And so with PSP, MSA, CBS, DLB, they pose inherent challenges, and that's for a few reasons. One is they're far more rare. So it's really hard to recruit people into studies when it's just a rare disease and you don't have the large scale clinical trials that you can run, which require a lot of people. Number two is the symptoms tend to progress more quickly and faster. And so people that are eligible for trials are only eligible for a certain period of time before the symptoms get too bad. And then we're not able to recruit anymore. And so while there aren't as many studies as there are for Parkinson's disease, there's still been a ton of work done for PSP, MSA, and CBS. And so these are two studies that were published last year for progressive supranuclear palsy. And so again, this was an antibody that was given into the spinal fluid again to attack this time the tau protein instead of the alpha-synuclein protein. And so once this antibody bound that type tau protein, we showed that the tau was cleared from the brain. But again, we didn't see any benefit over time up to a year out. And so people that got placebo did had just the same amount of symptoms as people that actually got the study medication. And so this is kind of the same story again. Are we looking at the wrong target on tau? Are there different parts of the tau protein that we need to attack? Again, is it the wrong method of delivery? Do we need to give it by mouth? Do we need to give it more frequently? Do we need to give it less frequently? And so the trials are definitely being reworked, and there are several ongoing still. And so this is a bit of a complex slide, but it shows 8 different mechanisms by which we think PSP could manifest in the brain. So why is PSP caused? And so in each of these 8 categories, or 8 categories, there are several clinical trials ongoing. So that's good. We're targeting different possible mechanisms of action to try and find something that slows down PSP. With MSA, there are currently 62 active clinical trials ongoing worldwide, which is actually quite impressive. We're a little bit behind PD, so far more with Parkinson's disease, but we do have multiple phase 1 studies that are ongoing for disease modification. And it's not just disease modification we're looking at, those autonomic symptoms, so lightheadedness and urinary symptoms that are quite severe in MSA, we're targeting symptomatic treatments and coming up with new symptomatic treatments for those symptoms as well. And so, lots of studies ongoing with MSA. And again, looking at potential causes of MSA, we've got 8 different potential causes here. And again, we're targeting each of these potential causes. So not just going down one pathway, we're trying to go at down a variety of different pathways to see whether one of them will potentially work. For dementia with Lewy bodies, there are 57 active studies that are ongoing worldwide. And for cortical basal syndrome, which is actually the rarest, or cortical basal ganglionic degeneration, there's 32 active studies ongoing. And so for a rare disease, it's quite hopeful to see that there's so many studies that are ongoing. So how do we determine a path forward? And like I said from the beginning, I think patient engagement is truly essential, because now not only do we have so many new symptomatic therapies available, the potential to participate in clinical trials is really growing. But each treatment and each trial is not really for everybody, right? There's certain recruitment criteria, there's certain medications that have side effects that may not be beneficial for certain people. And so it's really important to know the strengths and limitations of each option and speak with your physician about them, right? Being well informed, asking questions in your clinic visits. This is how we push the field forward, because sometimes clinicians may not be aware of ongoing trials, and they'll look them up, and then they can help not only you, but potentially other patients who have similar symptoms as well. And so coming to talks like this or visiting other websites with information that are out there, and I'll provide you with some at the end of the talk, really important to know what's out there, what might be good for you, and talking to your physicians about these options is super important. Teams in Alberta are growing, and so our movement disorders program here in Calgary has really exploded in the last few years. We've got several new physicians that have joined our team, and we're working really hard to bring trials into our province. I know that's been a problem in the past where the trials have been available elsewhere, but not here in Calgary. And so not only symptomatic therapies, but disease modifying therapies, we're trying to build the infrastructure where both government funded and industry sponsored studies are wanting to come here, because we can efficiently and easily run trials. And so we're getting there. We're growing quickly, and hopefully we'll have more trials soon. I think the other thing that I really want to stress is that there's no pressure to participate. Not everyone can participate in clinical trials. And again, that's for a variety of reasons that we discussed before. Getting to appointments can be tough. People don't necessarily live in the city. Coming to hospital can be stressful. People sometimes have had poor experience with the healthcare system in the past. And so, you know, I do want to say that it's important that, you know, if you're here and I just don't want you to feel any pressure to participate. Obviously, we're super grateful for those that do, but there's a variety of reasons why people can't. And so I think that's just an important thing to kind of keep in mind. And so if we go back to that 65-year-old gentleman who was diagnosed with Parkinson's disease in 1995, we've really made a lot of progress since then. And so that gentleman was actually my grandfather. That's what I looked like back in 1995. And so when I think about the progress that we've made since then, it really gives me a lot of hope that we're going to make even more progress in the next 20 years. But we're certainly not even close to stopping. We've made ground, but there's so far that we still have to go. And so part of that is developing new disease modifying therapies, but a big part of that is just investing time, effort, and money into developing these new treatments, right? And so when we look at neurologic disease as a whole, since 1990, Parkinson's disease has been the largest growing neurologic disease in North America. That's more than stroke, on a similar pace, slightly faster than Alzheimer's disease. And so we're seeing a lot of funding coming in from governments, from private donors, and from industry as well. And so I really think the time to invest in Parkinson's disease is now, and we're really hopeful based on the amount of studies and the amount of work that's being done. So some additional resources that I'll provide you with. The Parkinson's Association of Alberta website is great to start off with, and obviously you guys know about that because you're here. But the Michael J. Fox Foundation has a nice research subsection where they talk about ongoing trials and ongoing research. And then the clinical trials website, which is an international website, is clinicaltrials.gov. You can type in Parkinson's disease or MSA or PSP and just see all the clinical trials that are ongoing for your specific condition, and look at whether you'd be interested in participating or whether you could maybe even advocate for bringing a trial here or to Edmonton or wherever. And so I'd like to wrap up by acknowledging our team. And so this picture was taken just a few years ago, but there's a lot of people missing. And so we've made a lot of additions since then. And so you can see some of the neurologists here: Dr. Furtado, Dr. Martino, Dr. Sarna, Dr. Kraft, Dr. Quickfall, a psychiatrist. But Dr. Okino, Dr. Bruno, and myself, and Dr. Cieslak, we've all joined the team in the last 5 years. Dr. Pringsheim has been around a while as well. We've added a couple of geriatricians, Dr. Goodarzi and Dr. Sami, who are very good in terms of geriatric support. Doctors McLean, Williams, and Mackey are our neuropsychiatry team. And then, of course, our neurosurgeons, Dr. Kiss and Dr. Gergis. And I would like to give a shout out to our new South Health Campus team. This is a clinic that I started back in September, and it's a growing team, and we're really happy that we could open a second center here in Calgary to try and reduce some of the wait times and provide more allied health support with PT, OT, social workers, speech language pathologists, etc. And so this is our team here in Calgary. As I mentioned, we're hoping to grow further, and hopefully we can bring more exciting clinical research to Alberta. And so with that, I'd like to end, and then the chat box was kind of blowing up, so hopefully there's some questions that we can address.
Thank you so much for your presentation. It was lots of great information, and like you mentioned, very hopeful. We still have a long way to go, but yeah, it's great to hear what research is being done. So you are right, there are tons of questions, so we'll just get going. So the first one here is, there's a lot of new medications, some of which are not available in Canada but may be coming soon. Are there a place that people can look to see what medications are up and coming, or is that something they should check with their neurologist?
Yeah, so that's a great question, and looks like Jordan. Thanks, Jordan. I think on the Health Canada website, there's actually a section that talks about medications that are coming up and that may be approved soon or are currently being reviewed. And so that's a good resource to look at. And of course, talking to your physician is something to continually check with as well. But the Health Canada website has a good section for medications that have been approved elsewhere and that are currently being reviewed or being submitted to be reviewed in Canada.
Okay, thanks. And the second one here, what are the side effects that can be produced by DBS?
Yeah, great question, Karen. So, DBS is the electrodes are put in deep parts of the brain, and around those parts of the brain are the tracts that go kind of from the top all the way down to the spinal cord, right? And so sometimes people can get muscle pulling or muscle cramping because it affects the motor tracts. Sometimes people can get speech changes. Sometimes there can be numbness or tingling or a burning sensation. It just depends on which kind of tracts or structures that you hit that surround the part of the brain that we want to target. And so these are side effects that are obviously temporary, because if they're based on the stimulation. If they're a side effect from the surgery itself, where where it could be from a lesion caused by the electrode going in, those side effects can be longer lasting. But of course, that's a risk-benefit discussion to have with the surgeon. The side effect from the stimulation, we just turn the stimulation down, and then generally the side effects go away. So that's something to keep in mind.
Okay, thanks. There's two here that are quite similar, so I'm just going to blend them. If someone has previously had the DBS surgery in the past, would the new advances in DBS benefit them?
Yeah, so that's a great question. And so there's certain companies that produce certain electrodes that can produce that directional stimulation or that adaptive stimulation. And so replacing what you have already with new leads and then a new battery pack is not necessarily something that we can do just yet. But depending on when you've had your leads inserted, you can replace that battery pack, which then does allow for some variability in terms of using some of these new techniques. And so for the most part right now, if you've already had DBS, it's a bit tricky to kind of replace those leads with the newer technology. But I hope that one day we can do that.
Okay. And then there's another one here about medication. Do you have an opinion on the secondary mode of action for sulfonamide?
Yeah, so sulfonamide, yeah, so glutamatergic activity, NMDA kind of activity, it's a bit tricky. I have to say, I haven't been super impressed with my experience with sulfonamide. I used it in the US a little bit, and I haven't prescribed it yet in Canada in the 8 months I've been here. But I haven't seen as prominent a response as I had hoped. I don't have a ton of experience with it, to be honest, though, so.
Okay, thanks. There's another one here about the subcutaneous levodopa. Is it available when it's first available in the US? Then does it come to Canada, or will it be available here immediately too?
So one of the positives about that, Jordan, is that one of the trials was actually done here in Canada, so it should be here pretty quickly, right? So if the trials are done elsewhere, sometimes it's a bit trickier to get drug approval. But if a trial is actually done in Canada, some of the regulatory processes are actually gone through already. So sometimes going through Health Canada is a little bit easier.
Oh, good. Okay, that's good to know. One here, can you tell us a little bit about the challenges of diagnosing the cousins of Parkinson's versus Parkinson's itself?
Yeah, so that's a great question, right? And that's our kind of one of the inherent challenges we have with recruitment, because if we're not certain that someone has Parkinson's or PSP, it's hard to bring people into studies, right? And so we don't have a blood test, we don't have a spinal fluid test, we don't have an imaging test that that tells us for certain that someone has PSP or Parkinson's disease. And so early on, someone with walking challenges and stiffness and slowness could either be PSP, MSA, Parkinson's disease, dementia with Lewy bodies, cortical basal syndrome. And only over time do we notice that, oh, this is going way more quickly than I expected. Or, oh, look, now we've developed that asymmetry and this looks like more classic Parkinson's disease. And so that's kind of the inherent challenge. And so a lot of the studies want to recruit people early on because the symptoms are mild, and then you show that it doesn't progress as fast when you get the study medication. But if it takes some time to develop that diagnosis or come up with that diagnosis, it's a bit tricky to get people to enroll into studies. And so that's kind of the challenge that we face. And so developing biomarkers, which help us diagnose someone early on or even before they develop physical symptoms of a disease, would be super helpful in getting people into studies faster. So a lot of work being done into looking at that as well.
A similar question, how do I volunteer for an appropriate trial? And I wanted to add on to that question, can you register on that clinical trials website that you mentioned?
Yeah, so that's one way. Another way is in Calgary here, we've got a program called the CAPRI program, the Calgary Parkinson's Research Initiative. And so you can just ask your neurologist if you'd like to participate in that. And then it's a kind of a database where we keep patients. And then as trials come up, we can reach out to you or get in touch with you. And then again, at every visit, just important to ask, any trials ongoing. We have monthly research meetings where all the doctors are aware of all the trials that are ongoing in Calgary. And so if you come bring those up at our patient visits, then we'd be happy to put you in touch if there's one that you would fit for.
Good. And I will just add to that, if you are interested in getting involved with Capri, feel free to send your client service coordinator an email and we can get you connected. Another one here, what specific areas of research do you work in?
That's a great question. So my area of research is actually, I don't do clinical research. I just kind of help recruit for clinical trials and ongoing work done by my colleagues. My academic areas of interest are actually medical education, and administration. So I help train our residents and our medical students and things like that. So that's my area of research interest.
And another one, are they accepting new referrals at South Health Campus? Sounds like someone wants you to be their neurologist.
Yeah, so generally how things are working down here is in Calgary anyway, is our referrals all go to a central triage point, and then they're kind of delivered to the doctor that has the lowest kind of waiting list. There are people that have come and requested to see me at the South Campus just because they live like 2 minutes away or 5 minutes away, and getting to Foothills Hospital is a bit challenging. And so if you have a neurologist already but would prefer to be seen at the South Health Campus due to difficulty getting into Foothills, I'm more than happy to see you down there.
Okay, great, thanks. And one more here, if there was a more refined diagnostic test to allow for earlier detection of PD, would it make a difference in modifying the disease progression?
I think so, right? And I think if we can get people in clinical trials earlier on, we can really then see whether our protein targeting options are truly failing or not, right? And so if someone doesn't have motor symptoms and we give them like a protein targeting therapy and they develop symptoms at the same rate as someone who got a placebo medication, then I think we can say, look, let's scrap this theory and go back to the drawing board, right? But there's just so many questions that have yet to be answered in terms of the timing of drug delivery. So I do think a early biomarker, early detection or detector of Parkinson's and Parkinson's syndromes is super important.
Kind of a related question to that, do you know if there's any research ongoing for people who have had Parkinson's in their family, like yourself, who maybe don't have a diagnosis yet, but would want to participate in a clinical trial?
That's a great question. I don't know of any that are ongoing here yet. The Parkinson's Foundation in the US is doing a study called PD generation. I don't know if it's like generation, but the GENE is capitalized. You name things in funny ways. And so what that study does is anyone diagnosed with Parkinson's disease, they can get free genetic testing done just so we can build up a database of people with genetic conditions. So when we do develop gene targeting treatments, that we have a kind of a database of patients that would be eligible for those trials right away. Because if you can imagine, we develop something and we're scrambling to find people to enroll, it's a bit tricky, right? And so that's for sure happening in the US. I don't think it's happening here, but I will look into it.
Okay. And yeah, just lots of comments here saying thank you, and it was a really great presentation. I'll give it another minute or two to see if anyone else has a question. Okay. I think that might be it for questions. So thank you, Dr. Karnik, for your presentation this afternoon. We really appreciate you taking the time to come and speak with us and share your knowledge. Thank you to everyone who joined the webinar this afternoon and participated with some questions. And thank you again to the week sponsor, Hein Financial Group. Next Wednesday at noon, we have our third Lunch and Learn webinar, which is featuring a speaker, Dr. Richard Kamikoli from Edmonton, who will discuss the motivation to move. And you can register for that webinar online like you did for this one. Thanks, everybody, and have a great afternoon.